So the next section is going to launch off those deformity abstracts, and we're going to have a deformity symposium. The first talk we're going to have is Pierce Nunley. He's going to talk to us about pelvic alignment and why so many numbers mean so little time.
Thanks, Bob. So I was kind of asked to give this talk, and so for those people who are great deformity surgeons and understand everything about pelvic and morphological parameters, raise your hands. Understand it all? Okay, well, I got one or two. So take a break. Because seriously, you know, when you look at these and you go to different societies, part of my disclosures is I'm on the ISSG. I'm fortunate to be part of an amazing group of people that really look at these numbers hard, and we argue with each other and really go back and forth with good spirits. But nevertheless, the group has done amazing work over the years, and so most of the time when we go to an SRS talk, it is just and we're leaving a bunch of people in the dust. And so what I wanted to do was kind of put together a talk that some people are going to think this is extremely boring. Like, Neil, you're out of here. But there's some people in the audience that aren't into deformity, and I just want to break it down and start from the beginning and have kind of a basic talk on what are we doing and why do we do this. Well, first of all, is this myth or reality? And I also do, I want to back up and give special thanks to, because he's right here, Bob, and also Virginie Lafage and Frank Schwab for helping with some of these slides. So is this myth or reality? Well, you know, some people say, well, it's an art. I look at it, and I used to be one of those that never really measured anything. I don't want to use all those angles. I kind of know where my patients are. You're just complicating my life. Or are you over here with all these numbers and going, just you're a fanatic about measurements and measuring every single thing that comes in and wants another angle? And you know, even in the ISSG group, all of a sudden we come up with another angle and we're going, oh my God. And we try to see if that means something. Fortunately, most of the time it really doesn't. And we kind of break it down to the least common denominator. But if we go back to Cottrell-Dubussets and do a little history lesson, and this is 25 years ago, it doesn't seem like it. I'm getting older, I got gray hair now, but it doesn't seem 25 years ago, but it was, where we started really talking about the optimal alignment in this cone of stability that we're in. And we understand as we get out of that cone, different things happen because of our musculoskeletal system, neurological systems all have to balance all this. We don't think about it, at least those of us that are able to walk and not think about it. But this cone of economy is really kind of what drives everything. And whenever there's malalignment, we've also proven that this global loss of malalignment causes problems. Specifically when we look at plumb shifts starting to go anteriorly, this really does increase disability seen in the SF12, SR29, and ODI. I mean, it's just quite clear that as that increases, that causes problems. And likewise, when you have a lumbar kyphosis, it causes marked disability in these indices as well. But also when we drill down a little bit more into lordosis, we find that as we increase lordosis or develop lumbar kyphosis, again, ODIs go up and it's really not well tolerated. A lot of this goes back to the work that led by Frank and the ISSG back now about 12, 15 years ago. And it really looked at these traditional spinal pelvic parameters. And so when we looked at it, we're going to go in a minute, but if you don't remember what PII and LL is, but your pelvic incidence and your lumbar lordosis, basically those should be kind of equal, plus or minus 10 degrees. And then another one that was looked at was basically your SVA and how forward you are, so your sagittal vertical alignment and if you were going forward or not, it should be less than 5 centimeters. And then the last is your pelvic tilt. That's how much your pelvis is tilted, and that should be less than 20 degrees. And when we looked at these, we found that these were the 3 most highly correlative parameters among all the coronal and sagittal parameters and operative and non-operative things. These stuck out as the ones that really had the most drive, and they were also independent drivers of patients' outcomes. So let's just take a pragmatic approach to sagittal alignment. And when does it really matter? Well, sagittal parameters do correlate highly with health-reported quality outcome measurements. And when we look at spinal pelvic harmony, and again, we're not talking about an absolute value. We're talking about balance and harmony, really. PILL needs to be close to each other. And we look at pelvic retroversion and pelvic tilt. That's another parameter. And then truncal inclination. These are the ones that tend to drive that. So fortunately now we can do these full body scans and really look at with the EOS top to bottom and really see if a patient's retroverting their pelvis and really causing a problem. We can actually see that more so than a standing film that may hide that. But really everything sits on the pelvis. It's all driven from here on up. And depending on where the pelvis is and anything that's going on in the lower extremities, down to the feet even, that will have an effect on spinal alignment. And so, and some of these new parameters we're looking at are going, literally all the way to the cervical spine, all the way down to the ankles, to try to correlate those with spinal outcomes. But it's certainly the pelvis is the regulator. So let's go through this kind of in Spine for Dummies fashion. So pelvic incidence, which is on the left, and basically that's a line drawn from the midsection of the sacrum down to the middle of the femoral heads. Of course, they're never quite like that, so it's to both of them, and you average the two. Your pelvic tilt, which is basically the same line from the sacrum drawn to the femoral heads, but then a vertical, so whatever that angle is. And then a sacral slope, which is a line through the top of the sacrum and a horizontal. So this is a trigonometry problem at this point. And it took me a while to actually figure this out. But essentially, it's just trigonometry. Your pelvic incidence, by definition, equals your pelvic tilt plus your sacral slope. Always, every day, all day. That's the way it's defined. It's trigonometry. But the pelvic incidence is kind of interesting when we just look at it. As pelvic incidence increases, it's basically just telling us where the sacrum is inside the pelvis. That's it. That's all it is. And it's a morphological parameter. It doesn't change. It doesn't change once we're an adult. It does change a little bit as we grow, but that's separate. But it's there. It's done. And so, and as you go from a low pelvic incidence to a high pelvic incidence, it has effect on your sacrum. So this is how God made us. And this is what we start with. And now the body has to say, well, how am I going to compensate for that, each individual person? And so this is a morphological parameter. It's not affected by any patient position, and it just is what it is. So what's normal PI? Does anybody know a normal PI? Luis isn't going to say that. Well, there really isn't one. Doesn't really mean anything. It's, again, a number, but it's the number that you start then going off of to say, what else am I going to have to do? And if you don't get anything else from this, this is really important because we can look at lumbar lordosis, we can look at these side films, but if we miss that a patient has either a really low or a really high pelvic incidence, then we're now putting ourselves behind the 8 ball on how we're going to do something when we operate. And if you don't get anything else from that, because this you can't change. The patient comes with this. It has nothing to do with their degenerative disc disease. Is there pathological value? Again, not really. There's really, there are a couple of outliers, and I just wanted to throw that out there. So, high pelvic incidence has been associated with spondylolisthesis, and low pelvic incidence has also been associated with Charman's kyphosis. So there can be some correlations, but there's no direct correlation. So now if we look at sacral slope, the sacral slopes, it does correlate obviously with pelvic incidence, and a small PI equals a small sacral slope. So a small pelvic incidence, small sacral slope. And of course, the opposite of that is a large PI, pelvic incidence, will equal a large sacral slope. Now, what if we take normal patients and kind of look at them? Well, this is kind of, when we do that and take a bunch of subjects and look at pelvic incidence and their sacral slope, we find out that really these normal people have a wide range. So there really isn't a abnormal one. And then when we finally look at pelvic tilt, again, the definition is going from the mid point of the sacral plate down to the femoral head and back up. And again, that's just the orientation of now the pelvis, not the sacrum in the pelvis, that's the pelvic incidence, but now it's the orientation of where your pelvis is. And this is where compensatory mechanisms start to come in, and they're completely affected by the patient position. So as the patient retroverts their pelvis, you can see how their sacral slope changes, and so does their pelvic tilt, right? So if you look at how do you recognize a large versus low PT, start to look at those femoral heads. And yeah, I'm not saying I measure everybody, because if they're more in this kind of medium area, in other words, at one level, I might not do that. But once they start falling into the left side or the right side of the screen, that's when I can't do those calculations in my head. And that's when you really need some help. And again, if we put the two, pelvic tilt and sacral slope, together in normal patients, you again see that there's a correlation between the two. And you got to really be careful on low pelvic incidence, because that really has a high impact on your pelvic tilt. So if we're going to evaluate lumbar lordosis, how much do we really need? And again, we go back to the pelvic incidence and we go back to the specific pathology and specific patient. But again, the low pelvic incidence is a vertical sacrum, and a high pelvic incidence is more of a horizontal. I know I'm repeating a lot. That's why we drive these things in. So again, pelvic incidence is your sacral orientation. It needs to be ideal within 10 degrees. And we can kind of think about it as a football, a lot of football people here. So if you kind of in the middle, you kind of got your average PI and your average lumbar lordosis, that's a 50-50, that's a 50-yard liner. These ones are kind of easy. These are a lot of our patients. But then as we switch to a small pelvic incidence, that has an effect on lumbar lordosis. Now, what if you take that patient and say, man, I'm going to dial myself in 40 degrees of lumbar lordosis? You just screwed that patient, and if they're older, you just going to cause them a PJK. I mean, that's just plain and simple. What about a large PI? If they have a large PI, and I'm thinking, oh, I don't really need much angulation here. I don't need to get much lordosis. Well, yeah, you probably do. And so you need to understand that before you start the procedure. What about ASD? This is an interesting paper. I threw it in here for interest that when we looked at 45 patients that had symptomatic adjacent segment disease, there were 38 control patients, but what we found out is that patients that had PIL within the 10 degrees only had a 25% revision rate versus the patients that were corrected to greater than a PILL of 10 was 78% developed adjacent segment disease. That's huge. And when you looked at the value of that, that was a 10 times higher rate that somebody would develop adjacent segment disease if you did not correct their PILL mismatch. Just a huge, huge thing. So trying to drive that home, because these happen on these 1 and 2 and 3 level cases. And people that don't understand deformity. And we see that, fortunately, not a tremendous amount, but it happens. And when we look at what is the typical lumbar lordosis in a typical patient, it's kind of interesting. On the right side is how much the disc contributes, and on the left side is how much the vertebral bodies contribute. But overall, when you look at it, L4 to S1 contributes 66% of that. So that's your money spot right there, 4 to 1. And if somebody does a 4 to 1 fusion and screws them, and now we got something else going above there, we can't correct. I mean, we're behind the 8 ball. They've wasted the majority of the correction. For the sake of time, I'm going to kind of go back past kind of apex and kind of lordosis distribution. But again, this shows that you get more lordosis distribution in the upper lumbar spine and correction. And it does matter. In our study that we did, we noted that patients, if we undercorrected the distal lordosis, that they were more likely to get PJK than if we overcorrected. So don't undercorrect the distal lordosis. That has a definite problem with the thoracolumbar. Finally, age-specific approach considerations. So the traditional Schwab classification, we kind of looked at it. We looked at it based on age, and we found out as people get older, we don't really want to correct them as much. And so what we found out that the SVA, and look at the second to the right column, in 35 to 44, yeah, maybe a negative number, 45 to 54, 15 degrees, 55 to 64, 35 degrees, 65 to 74, 54 millimeters. So it's going, we don't want to say less than 5 on the 65 and older group. We don't want to correct them over, because if you do, you're going to have increased problems that we'll have to deal with. So younger and older, I mean, essentially, this is what happens. You see that one on the left, that's ideal. You get a little too ambitious, and then you end up getting a fracture and having to extend them. So how do I do it? There's different products out there. I use SurgiMap, and SurgiMap's free. Free! And so, and it's very easy to use. It takes a little bit. You can work it into your workflow. You can have your people in the x-ray department, you can teach a good tech or two how to do it. Just for the heck of it, I threw this in here. It literally took me less than a minute. I take an x-ray, I hit the little sagittal key, and I literally go beep, 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 click, that fast, and it gives me all of these numbers. That's that quick. So all you got to do is have it up there, have it ready to go, and you can do it. So spinal pelvic parameters, there really are essential radiographic measurements, and harmony is the key. It's all about balance. It's all about harmony. It's not about any specific number. And then there is an art to that, as we're finding out. And you got to disassociate the drivers of the deformity from the compensatory mechanisms and really start thinking that way. This is a reproducible process. It's just one parameter after another as you go through the preoperative thinking. In sagittal malalignment, this is not a new indication for surgery, okay? So that's one thing we want to be clear about. We've got all these numbers. But we do, if we got to correct something, we really have to know where to fuse and how to fuse. And you really want to get in the habit of measuring at least some of your cases, those are the high and low PIs, and take the time to work that into your workflow. Thank you very much.